Hi guys, how you guys doing? So for today's video, I'm just gonna go ahead and review the crash cart on the monitor. So here we go. Okay, so for your crash cart, what to know is you're always going to have your monitor that's on top of it, and you're also going to have a green bag that's normally there just for like extra suction. And other things that you're going to have is your CO2 detector that's normally on top of your crash cart as well. Okay, as you can see, the drawers are nicely labeled for us, so it kind of tells us on each drawer exactly what it has on there. So let's just review really quickly on the drawers. So your first drawer, as it says, IV supplies. So what that's going to have is going to have things like your flushes or anything that you need to do an IV on a patient or to draw blood on them. It's going to be right there for you on your first drawer, okay, including some needles and so forth. All right, it also has a razor as well on your crash cart, and that is very important because if you're going to put pacer pads on a patient, you want to make sure that you're not putting it on a hairy site. Okay, your second drawer, as you can see, we do have two pharmacy drawers that's on here. That's because your first pharmacy drawer mostly going to be your first line drugs and then your second line drugs. Okay, so let's go ahead and open it and see what's on our first line drug. The first line drawer is going to have medications like your dextrose, and that is for patients that are hypoglycemic, but they're unstable. Because remember, if we're using a crash cart, it's going to be for patients that are unstable, okay? Or the patients that doesn't have a pulse. So your D50 is going to be for hypoglycemic patients. Also, you have sodium bicarb. Sodium bicarb is there on your crash cart because if a patient have maybe acidotic, okay, if they have confirmed acidosis, then you're gonna have your sodium bicarb to be able to push and rescue your patient from there. Other medication that you're also going to have as your first line drug is you have etomidate here. Just so you know, etomidate is a medication that we give if we're ready to intubate the patient. Then they'll probably go ahead and get like a paralyzer and go ahead and use etomidate for your patient. And also we have amiodarone there as well as a first line drug. Okay, as you can see, this crash cart has 3 amiodarone vials that's on your first line drug, and that is because during a cold situation, if you're going to give amiodarone for someone without a pulse, the first dose is going to be 300. So you're going to go ahead and give your amiodarone, and then your second dose is going to be the 150. So you have exactly enough to rescue your patient, so you don't give above the maximum dose. Okay, so that's your amiodarone is there as well, and that's going to be your patients with tachyrhythms. Okay, also here you're going to go ahead and have your atropine. Just so you know, atropine are for those bradycardic patients, but like I said, it's going to be unstable bradycardic patients. They can get atropine. Maximum dose for atropine is 3 milligrams, and as you can see on your crash cart, you have pretty much up to 3 milligrams. So the crash cart is very smart, and it tells you exactly how much drugs that you need based on what they provide you with. Okay, other medication that's on here, you have calcium chloride. Really quickly, calcium chloride is going to be there for those patients that are hyperkalemic. So we want to be able to chase that potassium. So they're going to have that here as your first line drug. You can give calcium chloride. Then you may give your whole cocktail of D50 with your insulin, but calcium chloride will be there for hyperkalemic patients. And you have lidocaine here as well. Lidocaine is there as a first line drug because for patients that are pregnant, you would want to give lidocaine as opposed to amiodarone because the amiodarone is tetragenic to the fetus. So we want to make sure that we have that on board for those pregnant patients, that we're able to go ahead and give lidocaine. And of course, like I said, it's going to be for those fast rhythms as well. Okay. Epinephrine is also there for us as well as first line drugs because for patients that are asystole, PEA, drugs and CPR is going to be your best bet. That's how you're going to rescue the patient. So as you can see here, we have 1, 2, 3, 4, 5, 6, 7, 8 epinephrine. That is because you can give epinephrine every 3 to 5 minutes, and if you're doing the math, 5, 10, 15, 20, 25, 30, 35, 40, between your epinephrine and doing CPR, you have enough medication to rescue your patient for at least an hour, okay? So epinephrine, your dose is 1 milligram, and ACLS guideline, there's really no maximum dose for epinephrine, so you can go ahead and keep giving it, but just know there's 2 different concentrations of epinephrine on your crash cart. This one is 1 to 10,000. That's the one that you give if you do not have a pulse, but if you do have a pulse for those patients that are anaphylactic reaction, it's going to be 1 to 1,000. Okay, so that's your epinephrine. Your second line drugs, just be mindful also. Your crash card is also labeled for you with what each medication is, but always double check during code situation. Your second line has nitroglycerin. That's for your patients that are, maybe they're having like a heart attack, so you have your nitroglycerin to go ahead and hang. You also have dopamine as well on your second line drugs. So if atropine doesn't work for your patient, a second line is going to be your dopamine. So that helps to increase blood pressure and also helps to increase your heart rate. Okay, so your dopamine is here. Other drug that you have as your second line, you have also your amiodarone on here as well. As you can see, we had it in the first line. This is there as a second line because if your patient has a pulse and you need to give amiodarone, it's just a different concentration. That's going to be mixed with D5. Amiodarone can only be mixed with D5. This is why in your crash cart you will have 1 bag of D5 in there. That is specifically for your amiodarone. Okay, so if you don't have a pulse, it's 300 initial dose. If you do have a pulse and you're giving amiodarone, you're probably going to hang the bag with a concentration of 150 mixed with D5, okay? Other medication you have as second line is your norepinephrine. Another name for this is Levophed. So this is a vasopressor. That medication is for those patients with a very low blood pressure. So we'll be able to give the epinephrine to these patients, the Levophed, just to make sure that we're increasing that blood pressure. Just know that every time you're giving a vasopressor, the patient's gonna need a central line, okay? So they're probably gonna even try to get that central line in that patient because you can only give Levophed and those vasopressors through a central line because it's necrotic to the tissue, all right? Other medication you have as your second line, you have your nitrostat. Of course, for angina, you can give it sublingual just to kind of see if that helps with the chest pain. You also have adenosine on here as well. It's there as a second line drug because if someone has a SVT, they're most likely gonna have a pulse, right? So is there as a second line, of course, there for those patients that has SVT. Adenosine will be given. Just know about adenosine, it does stop the heart. So you want to make sure that you're pushing it very fast. You're doing it at the closest port, and you're also flushing as well because that's a very short half-life. So that's adenosine. You have Benadryl on your crash cart as well. That's going to be for these patients that are having anaphylactic reaction because, you know, if they're allergic reaction, we're probably not going to be opening up a crash cart. But if they're having anaphylactic reaction, throat is closing up, then that's any emergency. We're going to go ahead and give the Benadryl. And we also have Solu-Cortef on there for you as well, which is your Solu-Medrol anti-inflammatory. You have Narcan on your crash cart as well. Those are for opioid overdose. Just know about Narcan, it has a very short half-life. So once you give the Narcan, just make sure that you're watching your patient because you might have to give a few doses of it. Very short half-life. Furosemide, if your patient's having CHF exacerbation, then you can go ahead and give Lasix. We also have magnesium sulfate on the crash cart as well. Your magnesium sulfate is there for these patients. Maybe they're having like the pregnancy, preeclampsia, or these patients that are having torsades de pointe, they'll need magnesium. Or these patients that are having like an asthmatic attack because it can also be used as a smooth muscle relaxant as well. So just know that your magnesium sulfate is there on your crash cart to help rescue your patient. And the other dose of epinephrine is there in your second drawer as well. So this is the 1 in 1,000 dose for anaphylactic reaction, okay? So just remember, if someone is having an anaphylactic reaction, the dose is probably going to be 1 to 1,000 as opposed to 1 to 10,000. And it's a much smaller little vial that you're going to be administering. Also, you have flumazenil in your crash cart as well. Flumazenil is those medication that you give for benzo overdose. So just make sure that those are for these patients that have benzo overdose. They're going to be getting flumazenil just to make sure that we are reversing like the Ativan and all those other drugs. So that's flumazenil is there for. And we also have metoprolol in there, second line for any fast rhythm and so forth, okay? Other things that's on your crash cart, as you can see, like I said, you have your boluses of fluid on here. And like I said, you have your D5 to mix it with the amiodarone. So here, of course, you have your tubings as well. And you also have blood tubings available on there for you with extensions, okay? Other drug that we do have on here, we have NG tube. That's going to be your supplies that you need for interventions. You also have central line cards if you need it. anything like that, it's there for you. Maybe you need like an A line. All of that is here for you to be able to rescue the patient. It even has a manual blood pressure machine there as well. And it has a pressure bag if we need to go ahead and squeeze normal saline or anything like that. That is there for you, or if we need to go ahead and set up an A line, okay? Your last drawer is here. There's gonna be your oxygenation drawer. This is where you're gonna have your embo bag is there for you. Just know when you're embering a patient, just make sure you open it all the way and make sure you're connecting it to oxygen. That is there for you. You also have your intubation tray that's going to have your ET tube and everything that you need, including your OPA, just to keep the mouth open, okay? So that is your crash cart, all right? So now, next to the crash cart, you have your monitor. So just know for the monitor, there's 3 different modes any monitor has. It has your defib mode, and it has the mode for pacer if you need to pace patient, and you also has for cardioversion, okay? The rhythms that you want to defib are going to be your pulseless VTAC and also your VFibs. Those are going to be rhythms that you're going to defibrillate, okay? How do we defibrillate a patient? So let's just say now your patient is on a horrible rhythm like VFib, they need CPR and all that stuff. So how you're going to defib is you already have your joules. You can start like about 120. Your energy is already selected. You can go ahead and analyze. It's analyzing your rhythm for you. As you continue your compressions, you're doing compressions until it tells you to go ahead and shock the patient. Then just making sure that you are clearing the patient and everybody is not touching anything, including your oxygen. Then you can go ahead and deliver your shock, okay? Just make sure that you do have your pads on the patient, all right? The other mode that you're going to have is synchronized cardioversion. The only difference between this one and the defib is that now you're going to make sure that you're hitting the synchronized mode. I know this is sinus rhythm because my my little fake monitor here doesn't have SVT, but the rhythms that you want to cardio over is going to be your SVTs, okay? So you want to make sure there's little dots on top of your rhythm here because that tells you that you want a cardioversion mode. So once that's there, you're just going to do the same step as you would defibrillate. You already have your energy. I'm going to decrease my energy because if you're cardioverting someone, it's probably going to be a lower energy, like 50 joules. And then you're going to go ahead and charge, and then you're going to hit the shock as well. So this is how you would go ahead and cardiovert someone, all right? For pacing is the last thing I'm going to review with you guys. My monitor, like I said, I don't have my patient attached to a real patient, but you're going to set your patient on the pacer mode. Always make sure that you're setting up the rate, the heart rate where you're going to be pacing the patient. Let's say that you wanted to pace them at 70. So you're going to go ahead and decrease the rate here. So I have it at 70, and then you're going to go ahead and increase your milliamps. You're increasing your milliamps until you see a spike before each QRS, okay? Once you have a spike before each QRS, then you know you're pacing the patient. You want to go ahead and increase it once you have that capture, maybe like 1 to 2 milliamps to keep your capture. And once you have that, you're just going to mechanically check your patient because we always want to treat patients in that machine just to make sure that they do have capture. All right, so I love you guys. Thank you for being here. Remember, the world needs exactly what you have. All right,